It was an ordinary day in the clinic when Amelia, a 9-year-old girl, was brought in by her anxious parents. She was previously healthy, but was now suffering from fever, a hacking cough, and profound fatigue. Her lips were cracked and painful, her eyes red and swollen, and she hadn't been able to eat or drink properly for days. Her mother nervously explained, "It started with a fever and a cough about a week ago, but now, it's this rash." Dr. James Carter, an experienced pediatric infectious disease specialist, leaned forward to examine her. The rash was disturbing, vesicular-bullous lesions scattered across her hands and feet, with a few targetoid lesions on her trunk. Her mucous membranes were severely affected, with ulcers on her lips, tongue, and buccal mucosa. Dr. James began connecting the dots. For him, the story unfolded slowly. He started by taking a careful and detailed history. No new medications had been given, at least none linked to rashes of this severity. But there was a clue buried in the past week: fever, sore throat, and a persistent cough. These prodromal symptoms feel familiar, like the opening chapter of a condition I've read about before, he thought. His thoughts raced through possibilities. Could this be hand, foot, and mouth disease? Maybe. But the extensive mucosal involvement didn't fit. Could it be Kawasaki disease? The prolonged fever, the rash, and the mucosal changes could match, but there was no lymphadenopathy or extremity swelling. Then it struck him. Could this be Stevens-Johnson syndrome? There was no drug history to suggest it, but the mucosal involvement and skin findings were compelling. He recalled reading in UpToDate, in children, as well as in adults without a clear drug causality, polymerase chain reaction and/or serology for Mycoplasma pneumonia infection should be obtained in the early stage of disease and 3 weeks later. He said to himself, SJS following infection with Mycoplasma pneumonia, called Mycoplasma-induced Rash and Mucositis, MIRM, is a strong possibility. This was supported by the diagnostic criteria for MIRM, as outlined in UpToDate. Reactive infectious mucocutaneous eruption refers to a severe mucocutaneous adverse reaction that occurs predominantly in children and adolescents following a bacterial or viral respiratory infection, most commonly Mycoplasma pneumonia infection. It should be suspected in a child or young patient presenting with a mucosal or mucocutaneous eruption and a history of prodromal symptoms, including cough, malaise, and fever, preceding the eruption by approximately 1 week. Dr. James then began counting the diagnostic criteria for MIRM. 1. Mucocutaneous eruption involving 1 or more sites with less than 10% body surface area involvement. This criterion is met, he thought. There is severe buccal involvement along with eyelid erythema and bulbar conjunctivitis, 2 sites of mucosal involvement, and the skin involvement is less than 10% of the body surface area. 2. Presence of a few vesicular-bullous lesions, or scattered atypical targetoid lesions on the skin. Yes, a few target lesions are present. 3rd, non-contributory medication history. This also fits, there's no medication history. 4. History of prodromal symptoms, as cough, fever, malaise, in the previous 7 to 10 days. The prodromal symptoms are clearly there. With this in mind, Dr. James ordered nasopharyngeal swabs for Mycoplasma pneumonia PCR, COVID-19 PCR, and a respiratory panel PCR. He requested a chest X-ray, suspecting interstitial pneumonia, and a CBC and biochemistry profile. The chest X-ray returned without consolidation, but there was a mild elevation in neutrophils. This doesn't feel right, Dr. James thought. The absence of significant findings on the X-ray made him question the diagnosis of pneumonia. However, he remembered reading in UpToDate. Signs of Mycoplasma pneumonia vary according to the stage of illness. He glanced at the timeline in the UpToDate image and realized the patient might be in an early phase where radiographic changes are not yet evident. He also reminded himself that pneumonia isn't mandatory for diagnosis, as Mycoplasma pneumonia may cause a nonspecific respiratory illness, similar to an upper respiratory tract infection, such as a non-exudative sore throat, coryza, headache, ear pain, and prolonged cough. The nasopharyngeal swab returned positive for Mycoplasma pneumonia. The puzzle is finally coming together, Dr. James thought. Now, all the diagnostic criteria were met. He recalled, the diagnosis of mycoplasma pneumonia must be done in conjunction with a compatible clinical syndrome. Laboratory results alone cannot differentiate between disease and asymptomatic colonization or co-infection with a viral pathogen. As Amelia was immunocompetent, Dr. James opted for a macrolide antibiotic over tetracyclines or fluoroquinolones. He prescribed azithromycin, 10 mg on day 1 and 5 mg on days 2 to 5. He chose azithromycin because of its longer half-life and better tolerance compared to clarithromycin. He also noted that fluoroquinolones are reserved for cases where no safe or effective alternative exists to avoid unnecessary adverse effects in pediatric patients. With the initial treatment started, Dr. James admitted Amelia due to her poor oral intake, requesting IV hydration to address her inability to eat or drink, ophthalmology consultation to evaluate and manage her conjunctival involvement, dermatology consultation to confirm the diagnosis of SJS or MIRM, and monitoring for systemic complications, including pneumonia progression. Dr. James summarized the case to his team. This case reminded me that every rash, every lesion, every symptom is a piece of a puzzle. While some stories are straightforward, others demand we think critically, connect the dots, and remain curious. This 9-year-old girl's rash wasn't just a symptom, it was her way of telling us what her body needed, and we listened.